Our presenter today is Dr. Adam Perzynski. He's the associate professor in the departments of medicine and sociology at Case Western Reserve University, and he joined the Case Western Reserve University Center for Healthcare Research and Policy within the MetroHealth system as faculty in 2008. His current work is focused on examining the specific mechanisms through which social factors influence health and clinical care over the life course. His broad research interests include medical sociology, health disparities, social determinants of health, structural equation modeling, and qualitative and mixed methods. His edited book, Health Disparities, Weaving a New Understanding with Case Narratives, brings a compassionate, broad approach to educating health professionals about how social circumstances shape lives and health outcomes. Dr. Perzynski has recently spearheaded efforts to enrich multi-sector collaborations with a combination of large databases and community-centered qualitative evidence. As a transdisciplinary scientist, his publications span many disciplines and stand out against the backdrop of a career-long effort to infuse the study of biomedical scientific problems with the knowledge, theories, and methods of social science. Dr. Perzynski, you may share your screen.
Great, thank you so much, Jalise. I am super excited to join everyone today, and I struggled a little bit with just exactly what would be the most appropriate brief presentation for this group, given the title of the chapter and the contents of the chapter, which is really around sort of like solutions making for health disparities. And I think the teams that I work on, some of them look similar in some ways to the work presented in that chapter by Dr. Cooper. But other things are, given my background as a sociologist, are often maybe a little bit different and focus on different perspectives and pathways. And so I thought I would sort of go down some of those other pathways that are a little bit more focused on neighborhood, which I don't think I read a lot about neighborhood. There are some really nice passages about structural competency and cultural and narrative humility that I thought really impressed upon me when reading the importance of neighborhood. But I also think like the circumstances in the communities where all of our friends, neighbors, patients, and fellow citizens live are such huge contributors to disparities that it would be worth sharing a little bit of that with you today. So that's what I'm going to focus on. I have to move my windows a little bit. There we go. So I have tons of amazing collaborators without whom nothing I would show you here would have been possible, and a bunch of groups have funded a lot of this work. So I want to acknowledge that. So I'm just going to explore some linkages between health, disease, and social inequalities briefly today. So first, and this might seem interesting that I would choose a model from the National Health Service Scotland to talk about health disparities in the United States. But I actually think that this crew did a relatively awesome job in creating a visualization that summarizes health inequality well. And one of the reasons that I like to use this slide is because if we look at most of our efforts in healthcare to address social determinants and health disparities, we have a strong tendency to focus at this sort of yellow colored box, which are things that are the individual experiences. So individual experiences of the economy and work, of physical spaces, of learning, of services, and social and personal. So providing more services is often part of that. But we also need to recognize that there are some more fundamental causes of health inequalities that we also need to work at, that are sometimes not so interpersonal and they're more structural. And I think this group lays out some of those. I don't think that's an exhaustive list in the purple bubble that you see there, but I think it's a good list and it provides a framing. And I'm going to talk about mostly the neighborhood element of those fundamental causes in this sort of brief presentation. But to give an initial summary, think it's important just to acknowledge that disparities occur in the context of broader social inequality. They're avoidable. Social determinants are a key driver, and there are many complex current and historical contributors, including but not limited to bias, stereotyping, prejudice, and clinical uncertainty. This slide, I just like to put it in here that there's not been another study of this for almost 20 years now. But this particular statement by the Centers for Political and Economic Studies found that 3 years of disparities, like just correcting only the Black-white disparity gap, so only the gap between African Americans and whites, in only a fraction of the conditions where there is a health outcomes gap, so only direct differences, that would save $230 billion, and that 30% of all direct care costs incurred in the United States are due to health inequities. So a third of all the money we spend on healthcare is due to health inequities. And then I like to highlight this figure. Our nation used to produce a national healthcare quality and disparities report. That report was ended somewhat abruptly with the Trump administration. So we don't see quite the same report since some change in leadership many years ago. But one of the notable things from this figure is just that for the vast majority of health disparities and health inequities that we can measure, whether we're measuring them at low income, very low income, or middle income persons, health inequity gaps are either worsening or not changing at all. And we're not doing a very good job in resolving them. And the same is true as if we look across the types of areas that a person lives in. And so I like to show this one simply because what we see here is that actually, as a nation, there are more new health inequities being observed in areas outside of cities, which is something that I think is often not acknowledged. So that when I'm talking about neighborhoods, I'm not just talking about neighborhoods and cities, it's also in other types of communities. So this is some data, older data from MetroHealth Institute of Hope showing percent with social needs prior to the COVID-19 pandemic based upon direct care surveys of 16,000 of our patients. And what you see is a really, really high constellation of this factor of social isolation as the leading social determinant of health when we screen people among the questions that we ask them about. And we see that this is really highly concentrated among young people, but also severe among all groups. If we think about Cleveland, one of the things that we know is that 95% of children are lead exposed, and in some neighborhoods as many as 40% are poisoned. Meanwhile, we have other neighborhoods outside the center of Cleveland where less than 1% of children are lead exposed and 0 are poisoned. I'm not going to talk too much about this lead exposure slide. So a ton of my work focuses on neighborhood and community disadvantage. And so what I want to show is right now there's a call out in this. This is a visualization of the area deprivation index, which is a composite score of 17 indicators of socioeconomic position. This comes from the Neighborhood Atlas from Amy Kine's group at the University of Wisconsin initiated this. And the draw out there in the top right is really University Circle. And so even though it's a triangle, according to the census block groups, that triangle is a sort of little teeny island of low socioeconomic disadvantage that is peripherally surrounded by immense socioeconomic disadvantage. And I think it's really sort of nice to contextualize where we're presenting from, or many of us are joining from today when we talk about neighborhood inequalities. And so this is just a plot that our group did that examined the association between census tract level area deprivation and life expectancy. And what we see is a dramatic drop in life expectancy according to the area deprivation index. It's sort of roughly slightly less than 20-year drop. And a lot of people have talked, and I think in Dr. Cooper's book, she talks about the difference between East Baltimore and another neighborhood and talks about the some specific cases. And then she also cites these major differences in life expectancy that occur similarly in Baltimore as they do in Northeast Ohio. And so we see that when we look, if we look at every state in the United States by census tract, this is sort of a wedge plot, where we can see by state the distribution of census tracts in the left column according to life expectancy, and in the right column according to area deprivation index. And you can see how the two track very, very closely within state. There are a few outliers that you can see. So there are a few places like Delaware where the life expectancy doesn't track quite as well with the area deprivation index, but overall the national trend is immensely powerful. So if we look at the effects of neighborhood on health outcomes, there was this early paper by Amy Kine's group using the area deprivation index, which found a powerful association in a very large cohort of Medicare patients just with 30-day readmissions. But since then, we see all kinds of really interesting findings. So we find that neighborhood socioeconomic conditions are associated with whether neonates stay longer when they have opioid withdrawal. We find that kids with cystic fibrosis are more likely to get antibiotic-resistant infections. We find that persons on Medicare are less able to manage their chronic conditions. We find that persons who have total hip, total knee replacements have worse functional outcomes and worse physical and mental health outcomes after those surgeries if they live in neighborhoods characterized by lower socioeconomic position. And in my own work, one of the things that we found is we find that among persons in Cleveland, when they live in low socioeconomic condition neighborhoods, we noted that they're far less likely to have internet access in their home, which constrains them from using tools like the internet. In this paper in Northeast Ohio, what we did is we took the pooled, this is with colleagues at Cleveland Clinic, Jared Dalton and others, where we took the pooled cohort equation. So the most widely used prediction of cardiovascular events that we can think of, sort of Framingham-based initially. And we adjust that for person's neighborhood socioeconomic position. What we see, so these are just suits, I'll sort of go back and forth. This is the map of area deprivation, and this is the map of hard cardiovascular events in Northeast Ohio, using data from hundreds of thousands of patients in the electronic health record. What we find there is that 40% of all the variation in who has heart attacks and strokes in our region is explained by neighborhood socioeconomic position alone, instead of just the clinical indicators. We also looked more recently at about 40,000 smokers at MetroHealth. And here what we found is that among smokers, even in adjusted models, persons in high area deprivation neighborhoods had almost 30% higher odds of developing lung cancer, based even after accounting for their smoking intensity, their history, family history of cancer, many other risk factors. And then also very important in this particular table is what we found was that the racial disparity in lung cancer was fully mediated by neighborhood socioeconomic position. So that's the tale that I'm here to tell you. And then the other tale that I'm here to tell you is that given this immense burden of community and neighborhood factors on health outcomes across all neighborhoods in the United States, I think if we're going to talk today about the book and about pathways to reducing and eliminating health disparities, that we also need to talk about directly addressing the conditions in our neighborhoods, how we can improve housing, transportation, the way that people connect with one another, how we can improve seemingly simple things like tree cover, access to green space, walkability, park scores, and those kinds of things. So that's all I've got. And I look forward to this rest of the discussion.
Thank you, Dr. Perzynski. Could you talk a little bit about your experience or thoughts on the role of community development corporations in this work?
Wow, that is an awesome question. So Northeast Ohio is this really fun and interesting place, in part because we have one of the nation's longest histories of having community development corporations being actively involved in directing resources to specific areas of our communities, right? So like not, so first in Cleveland, so we sort of assume like, oh, community development corporations, CDCs. Like there are plenty of cities in America where that it doesn't even exist. Like no one would know what you were talking about. They tend to be funded by community block grants, but there are lots of funding streams. And so they cover pretty much the entirety of the city of Cleveland and some areas outside the city of Cleveland. And I think, you know, in our own work to address disparities, I'll give my favorite example is a recent project that we did as part of the Eco District in the Clark Fulton neighborhood, which is tightly linked to MetroHealth's campus transformation effort where we're building this 12-acre park. One of the things that we wanted to do was bring some community voices into our work as part of the transformation, right? We can't just build a ginormous, you know, almost $1 billion hospital in someone's, you know, literally in some people's front yard without talking to neighbors and community members. And there were some questions, well, how is this going to impact people's health? And the question that I wanted to answer was, well, how do people define health? Are we even on the same page in terms of, do we even have a shared vision of that? And here, community development was the key because we were able to go to the folks at Metro West and say, like I don't live in Clark Fulton, and I only know a couple of people who do, but we can talk to community development, have a strong, trusted relationship with their neighbors in Metro West. In Clark Fulton, the folks at Metro West have that relationship and they work for decades to build that relationship, and they've had projects where they're door knocking and they understand the landscape of dollars and investment. And so when we wanted to do that, we said, Ricardo and others at Metro West were able to introduce us to important layers of faith-based leaders, and we ended up going on walks with people in the neighborhood, and we asked them, what does health mean to you, right? So I think in many ways, community development is this amazing feature of our communities that like doesn't only sort of sponsor, it's not just the group that you go to when you want to know where to put your building or where investment is being directed or how you can get financing for a particular project on a street corner, but they're also the folks who really, you know the neighborhood and know the people in the neighborhood and are amazing at sort of sponsoring and directing neighborhood improvement. So I think in many ways, it's like one of the best starting points for any particular project that you could think of, whether it's building a park or doing hospital at home or a community health worker project to improve blood pressure, or something like we read about from Dr. Cooper. I mean, I feel like community development is the place to go. Now that all the CDCs are gonna be, they're all gonna be like, saying like, oh, Adam, why did you send all of these folks at us? Like we have other work to do. But for the most part, I think they're really this sort of fantastic place. They also, you know, in Cleveland, because there's such a tight link to the city council members for the wards between the council representatives and the CDCs, it also gives you this relatively unheard of connection between local policy and health improvement projects, which I think in other cities that you may not have that opportunity to, you know, as a researcher in a lab to direct your work directly, you know, like you might have the ear of a council person or six, simply because you chose to engage with the CDC at an early stage of your research project. Sorry, you got me all excited there. I was like, talk about that all day.
As Rachel said in the chat, we are former CDC employees, so we're just like kind of glowing and smiling, and totally believe that this is an undertapped resource, especially in the healthcare and research space. So we didn't pay you to say that, but you did say it, and now it's out there. So
Good. I would say one other plug, since it's Old Brooklyn Community Development Corporation. He's not there anymore, but Jeff Vesper had this wonderful idea when he heard that hospitals were mandated by the Affordable Care Act to do community health needs assessment. He and the folks at Old Brooklyn felt like, oh, well, CDC should also be doing a community health needs assessment for their neighborhood. So they did the nation's first neighborhood level CDC initiated community health needs assessment, which guided all sorts of awesome policy priorities and activities that are really, I think, improving the health of residents in Old Brooklyn.
absolutely. Thank you. Any other questions?
I guess I'll jump on something you said. Hi, Rachel from Mount Sinai. And we met at the Schubert Center dinners. So I'm curious about, given, I guess jumping off of what you were saying about CDCs and their proximity to their council people, I'm wondering, given your research, what are there ways to legislate at the local level to mitigate some of this, some of the disparities we're seeing, or what are the ways, I guess we're coming up on election time, what should be in our minds as voters and the ways that we can legislate towards change?
Wow, this is an awesome question. I feel like there are 100 ways that I could answer it. And I think my favorite way, a former faculty member here in the School of Medicine, Amy Schoen, used to like to say as often as possible, and actually Scott Frank says this too, that health is hyper-local. And so like that phrase is really critically important. So that like, if we think that we want to improve on health disparities and create health equity in our communities, then a one-size-fits-all approach is not going to work, even in Cleveland. So the policy priority for Clark Fulton on the near west side might be a radically different policy priority than the policy priority in other communities in Cleveland. And that is often borne out in data. So the example that I will give from Clark Fulton is, and most people aren't aware of this, and I love to talk about it. So despite Northeast Ohio and Cleveland's infant and maternal mortality crisis, what we know is that the Clark Fulton neighborhood for almost a decade has had one of the lowest infant mortality rates, not only of any Cleveland community, not only of any Northeast Ohio community, but of any Ohio community. So some things are going right. So as we were in the early stages of the Eco Districts project, a consultant from an outside firm came and offered to provide solutions and said, like, look, I understand that Cleveland has a huge mortality crisis. So I think infant mortality crisis. So I think we're going to work to address infant mortality in the Clark Fulton neighborhood. And so I couldn't have been more again. I was like, wow, you really have no idea what is going on over here. That is not the issue right now in our neighborhood. It might be the issue in another neighborhood in Cleveland. And so I think that from the ability of the council persons to direct some of their budget and resources to the specific priorities of the neighborhoods that they represent is absolutely critical. For many years, another example I'll give is that in Ashbury, right on the very edge of the triangle I showed, sort of the north edge of the triangle there, we have the Ashbury Senior Computer Community Center, directed by Wanda Davis, which for the past more than 15 years has provided basic digital computer literacy and internet connection skills and resources and computer devices to more than 5,000 older adults in the Ashbury neighborhood. And Wanda's work has been partially sponsored by Councilman Kelly. So I think that is, and irrespective of the financial supports, is of sort of a direct way of addressing a direct need in that neighborhood. I think that one is really special, and is, you know, similarly, I think we can say Old Brooklyn had the former council representative from Old Brooklyn almost 20 years ago created a free public Wi-Fi network in Old Brooklyn. Cleveland is the second most digitally divided community in the United States. And so to have your local representatives sort of creating direct benefits that are reducing social determinants of health on the ground in a neighborhood is almost irreplaceable. Oh, wow. Dr. Davis, one that was not. So I think I gave a couple examples of more successful investments. And without sort of maybe being too specific, I think I'll give a general example that has been tried in many cities, and that I'm currently part of a project in the developmental phases to focus on. So in Northeast Ohio and in the city of Cleveland, actually, in the city of Cleveland, I want you to think about how many pieces of vacant land do you think we have? How many vacant parcels? So like, come up with a number in your head. The number is 30,000. 30,000 vacant parcels in the city of Cleveland. So vacant parcels in Cleveland and other communities that were hard hit during the financial crisis and hard hit before that present an opportunity for investment and decision making about what to do with those vacant parcels. And I think here is an example where, in response to Dr. Davis's question, where so some communities have done a bad job or made decisions that were unfortunate with vacant land. And so one of those decisions is rapid development without taking into account the challenges of displacement that can be faced. So that if we take a large group of vacant properties and we pour all sorts of capital in them, we can build lots of new and wonderful things, but we might displace the folks who live there. They may be folks who are already struggling to afford their monthly rent. And so now we're pushing them out of a community that they had housing security in. But now we took a community that had vacant land, but relative housing, perhaps relatively stable rents and housing security for the residents there. And we actually created housing insecurity because with our development, I know this is like front and center for a lot of CDC directors too, so that when we conduct neighborhood improvement and neighborhood redevelopment efforts, whether it's greening a single parcel and planting trees, or whether it's more substantial development, really thinking about the policy levers that need to accompany that to make sure that we're investing in a way that sort of lifts all boats, such that everyone benefits from that investment, as opposed to maybe some small group of real estate developers and some folks who want to move to the trendiest urban neighborhood.
Arlette?
Elections is coming up, and so I was just thinking about when Trump ran, the year he won, and I was thinking about the people who in the rural communities, when they said we're going to get rid of Obamacare, and people were like, yes. But then when it came down to what to replace it with, a lot of people were left out in the cold because they thought Trump had their best interests. So how do we get people to understand that when we talk about caring in the sense of health disparity, it's not just an inner city thing, but it also, the people who were Trump followers were really feeling abandoned by not having the support that they thought they were going to get. And how do we help them to understand? And I don't know if you have any suggestions, that this is all of our concerns. And so whether you're in the rural area or the inner city, both need to be cared for in a way that supports everyone when it comes to healthcare.
This is awesome question and comment. I don't think we can underestimate the power of the problem of ignoring folks in rural communities enough. I don't think we can overstate it. The challenge here is we have folks, I think I have a few projects in the very southern tip of Ohio, where we've talked to some folks who, since the Affordable Care Act, what they've seen is that the hospital in their county closed. 5 primary care clinics in their county closed. And the only health plan that they have requires them to travel 115 miles out of county to see their doctor. So one of the most fundamental things in Dr. Cooper's book that she talks about very early on in the book are just like simple things like care access. And so that, like, if we've reduced care access in some communities, and that care access was reduced in part due to policy change, then our political leaders need to own the mistakes too, right? And I think like no political leader really wants to own the mistakes, but we do need to own the mistakes. And if people have less access to care, at the same time that we were attempting to improve access to care by expanding insurance, then that creates a problem. And so I think, I have many projects from the Health Resource and Services Administration that have been designed to build healthcare workforce and really help address some of those gaps. I feel like we could increase the budget of those programs that are seeking to improve access in rural communities by 20 times, and that might be sufficient to reach the need, right? So that imbalance is a very clear imbalance currently that is in dire need of being addressed. I think the challenge is very real. There are other challenges. Some of those hospitals closed and they were of poor quality and they couldn't make money, but I think and maybe somebody traveling further would receive better care at another hospital because the place that closed was of low overall quality, and they did very poorly in risk-based contracts, and so like they lost money and they went out of business and they didn't get bought by anyone. But on the other hand, for the folks who live in that town, the pain of seeing that local, whatever, insert the name of a saint attached to a hospital, seeing that close after being an asset in their community for 60 or 80 years brings about a lot of pain. And I think that's something that we need to respect as being very real. And I'm seeing a bunch of questions and raised hands, I think.
Sarah?
Yeah, I'm curious what you think of Habitat for Humanity's. I know for a while there, they were rehabbing homes. And then in the Woodhill neighborhood on Grandview Avenue, I know we, in my church, we helped build a brand new home, albeit for a low income family. It wasn't to be, a really nice home or anything, but it was certainly much better than what they'd been living in. So I'm just curious how you feel Habitat has helped with some of this vacant land sort of thing.
I think it's one of many very critical efforts. I think the one challenge that CDCs and policymakers and city planning commissions and any organization that's seeking to improve neighborhoods has to deal with is how to prioritize the use of that vacant land, right? Do we prioritize building a new home there? Do we prioritize building an entire block of new homes? Do we prioritize creating a park? And then, when you have such a huge number like 30,000, like how do we choose which of those, we're not going to build 5,000 new homes. Like Habitat for Humanity or any organization is not building 5,000 new homes out of those 30,000 parcels this year. In fact, maybe we would do 50. So if we were going to choose 50, how do we select which 50 that is? And I think one of the more interesting things happening is the idea that we could use evidence about the health and social conditions of our communities and estimate like where we would have the best opportunity to reduce disparities gaps and maybe target resources and so maybe directing those resources specifically to the places of greatest need where we can recover the most immediate benefit for those folks who are currently being left behind.
Do people like yourself ever get consulted by places like Habitat to decide where to put their money?
So we are, at present, we are literally developing a project where we would provide a parcel level dashboard that would allow any such agency to use data to inform those decisions. It's very challenging. What I would say is there are folks, actually I met this group from Wayne State in Detroit. They have a system called the Phoenix system, which takes data from the electronic health record, which is a nice choice for an acronym. Takes data from the electronic health records of Henry Ford Medical System and those care institutions affiliated with Wayne State, and estimates at the local level all the way down to the census block group quarterly blood pressure, right? What is the quarterly average blood pressure for everybody seen from this neighborhood in the city? So that so in Detroit, actually, which faces very similar challenges to Cleveland, that resource in many ways already exists in some form, in the idea that we can look at very, very specific indicators of cardiovascular health and understanding what those look like for each community that you might invest in. So I think there's a little bit of that happening. I think we're sort of like, we're in this world where data is growing faster than we can, far faster than we can provide thoughtful uses for it.
Thanks.
Hi, Adam, I have a question. That was a great presentation, very insightful, and especially for someone that is new to the area of Ohio, what the differences of disparities is compared to the nation and so forth. And I was really, I guess I was really intrigued by the heat map that you had with the cardiovascular related diseases to the income level of the area that you looked at. And one thing that you mentioned was when you're asking the community about health, what does that look like for them? Like what we may define or health providers may define as good health may be different than what someone in that community might define as good health or health needs, right? Because you're naturally, if you have grown up in a low income environment, you've known to tolerate certain things that if it does not prevent you from going to work, you just work that out and it becomes your baseline health. And so you don't realize that's not normal. So what is something, or how does your team, or how do people in general that study this area determine, or I guess, how do you go about asking or finding out what is the health issue?
Dr. Cannon, this is awesome. I feel like 10 years ago, that was the question that I was asking. It's like, how should we do that? I think one of the most awesome things being done anywhere on this question is done by Andrew Curtis and Jackie Curtis, professors in the School of Medicine, who use spatial video geonarratives, which is a high-tech way to do qualitative studies of communities, where they put a 360 video camera on an interviewer or on a participant and walk through a neighborhood while geolocating them and asking them questions about the health and the circumstances of their community. And then they've built software that allows you to sort of tie specific qualitative thematic findings back to very, very specific point in time locations, stick pins on a map. It's kind of one of the most awesome things that anybody has done. We did a low-tech version of this in Clark Fulton, where we didn't use the video cameras or the geolocators, but we just drew out the maps on paper as people walked us around, and we audio recorded them. And one of the most notable findings there is that when we ask people about health and their definition of health and their view of health, they tend to use words that are very, very social, as opposed to words that are clinical. So we don't hear much about blood pressure and diabetes and A1C or cancer screening. And instead what we see here are statements about how how people in a community connect with one another and how much they trust one another, as actually indicators of their own health. So that so really sort of viewing like their social interaction with their neighbors in the physical spaces of their neighborhoods as, not like influencing health, but as being defined as health, which I think was a somewhat surprising finding for us. Because it wasn't, and we would ask people like, so you mean how you're interacting with your neighbors, sort of shapes your health? And like, no, I mean, that is what health is. So I think, really a very different view than maybe we view it, even in our primary care clinic. Also, I want to know, I think I'm trying to catch up with the chat a little bit, and some folks were asking about the book. And so I would say like nobody, I mean, it's nice if you want to buy a copy because you like paper, but even if you do want that, as long as you're using a CWRU credential or most any university, the book is totally free. So like, do not buy it. Like, it's free for everybody at 1,600 universities that have a subscription to Springer Link, like Case Western. That's why we chose them as a publisher. So I've dropped a link in there. Also, if you do really like paper, the paper version the paperback one you can buy that I think you should be able to reach via that link is much cheaper than the Amazon one. It should be it's like $20 or 25. It used to be like, last time I bought them, they were like $20. So yeah, don't pay the whatever price you're seeing anywhere else.
Thank you.
Yeah. And then I also, related to the book, Dr. Adebambo, who's the co-editor of that, just received yesterday an offer to publish from the same publisher for her new book, which is going to be on microaggressions, racism, and allyship in healthcare, which is a similar edited collection, but is focusing more on the stuff that I think was really covered nicely by Dr. Cooper in chapter 2. So topics around implicit bias, but I think Baudet's approach is a little bit different and really sort of eliciting stories and cases of like the types of challenges that we encounter specific to racism in healthcare settings even today, right? Stuff that could have happened yesterday that we shouldn't, allow happen tomorrow, and really documenting that with almost our sort of like folklore lens, but also an improvement lens and focusing on how we can do that. So I'm super excited for her, and it looks like are giving us a submission date of May. So I think so this time next year, there might be another really interesting resource that would also be free.
That is great to know. I feel like we had an insider scoop there. So thank you, Dr. Perzynski. I actually have another question. And please, anybody else, if you have one, you can go before me, but if not, I'll go now. It's about building trust between healthcare systems and underserved communities. So this was discussed in this chapter. And number 4 talks about establishing, monitoring, and sharing progress on metrics that measure progress toward agreed on areas of focus. So it also relates to Dr. Cannon's question about how do you identify these priorities. I don't think that this, a lot of us that are engaged in this work, especially in a non-clinical way, how can we best establish, monitor, and share progress on these metrics, and really making sure that that dissemination goes out to the communities that we're trying to serve?
Wow, what a question. I mean, if I had a magic wand version of my answer here is probably my favorite one. And it would be, University Hospitals is turning on the EPIC system in about like 5 months or whenever their timeline is. And so that you're going to have 90+% of all human beings in Cuyahoga County, at least, on one integrated electronic health record system. If we could leverage that resource, and we could get over whatever reservations we have about sharing and confidentiality and stealing one another's patients and billing opportunities, then, and we could actually provide high resolution probably down past the block group. Information on any leading health indicator that's measured in health systems, and then share that same information in some protected way with folks at community development corporations, with our council representatives, with our governor, and with the folks who are working on various community information projects. And if we could integrate that, so I've not done yet, there's one more layer. If we could integrate that data with the data that Cuyahoga County collects on the characteristics of every property. So it's the things that are done in the Poverty Center here at our university. We generally maintain for the city and for the land bank a system called NST, which includes parcel level data on housing and properties. So if we could integrate those resources, plus with data that the county has on child protective services, data that we have on who uses the SNAP program, data that we have on who is homeless in any given year. If we could bring all of that together and share it with the folks who really are in positions to make important policy decisions and direct funds, right? Like I was sort of thinking like these ARPA funds, right? Like to your question, right? Like there's so much money, right? Like there's all this money. And the decisions that I was meeting with a political scientist a month ago, he said, well, one of the first rules of public policy is that policymakers do not require evidence to make decisions. And it's like the most disheartening, but the most enlightening statement I've ever heard. Right? Like, oh, that is totally true. Like, you do not need any evidence at all to make a decision. Like, it's not a requirement. It would be nice if we used it, but most of the time don't. So if we had the ability to take that kind of evidence and have it be available transparently for organizations, first, it might hold our policymakers to being accountable. And second, when we have these massive windfalls of money, whether it's from a tobacco settlement, an opioid settlement, or from policy that's made to send money to communities, it might help us really sort of capture value in communities by directing that money in ways that actually create value. Not that the decisions that folks have made will not create value, but I think we might make different decisions if we had that kind of evidence. So yeah, that's my magic wand response.
All right. Thank you very much, Dr. Perzynski. We really appreciated your presentation and your facilitation and just all of your insights. Very excited about the book coming out next year as well. So please feel free to reach out to the CTSC. We'll make sure that everyone in our research community knows about it because we can't learn enough, that's for sure.
Well, thank you.